Bismillah ar-Rahman ar-Rahim. We are discussing disorders of the esophagus, and today we will discuss the vascular and inflammatory disorders that are associated with the esophagus. In our previous lecture, we discussed the obstructive disorders, in which we discussed the uh, mechanical and functional obstruction of the esophagus. So today we will discuss those disorders of the esophagus that are related to the vascular system, and we will also discuss various disorders that cause inflammation in the esophagus. The vascular and inflammatory esophageal disorders include esophageal varices, which is a vascular distal esophageal disorder, and that is most commonly associated with portal hypertension, increased pressure in the portal vein that leads to the liver. We will also discuss esophagitis, which means inflammation of the esophagus, and the esophagitis is associated with lacerations or tears that occur in the esophagus. Various chemicals, for example, corrosive oils and other chemicals that cause inflammatory changes and cause inflammation in the esophagus, and we will discuss various bacterial, viral and fungal infections that are responsible for the esophagitis. Now, first of all, we discuss esophageal varices. The As I said that the esophageal varices, it is a vascular disorder, and to understand the esophageal varices, we must first make a brief review of the portal and caval circulation. We know that the blood from the whole of our body is returned to the heart through the two major veins, the superior and inferior vena cava. The inferior vena cava returns the blood from the lower part of the body, while the superior vena cava uh, drain the upper part of the body, and this venous blood goes into the right atrium, then into the right ventricle, and then into the lungs for oxygenation. Now, the superior vena cava and inferior vena cava and all of its veins and vessels, it is known as the caval circulation. So I said that the superior vena cava drains blood from the upper part of the body, and the inferior vena cava drains blood from the lower part of the body. But here, from the intestine and spleen, the blood doesn't return directly into the heart. The blood from the spleen and most of the gastrointestinal tract, it is brought by the portal vein into the liver. And this is must, because the food that we take and whatsoever the nutrients, macronutrients, micronutrients, vitamins, minerals that are needed by the body, and they are present in the food, so they are absorbed from the intestine. And in the portal circulation, they are carried into the liver, and the liver, which is the major metabolic machinery of the body, it processes these macronutrients like proteins, carbohydrates, fats, and micronutrients uh, like vitamins and minerals. And all these things, they are further processed and metabolized in the liver, so that to make them ready for use by the body. So this circulation is known as the portal circulation, and it is a little different from the caval circulation, being that in portal circulation, the portal vein, after originating from the gastrointestinal tract, it breaks down again into small uh, vessels in the liver. So we know that our body's circulatory system is closed, and there is no mixing of arterial and caval and the portal blood. However, there are 3 points in the body where the caval circulation communicates with the portal circulation. And any problems that occur in the liver, it will cause these communications of the portal and caval circulations. The increased pressure in portal circulation that commonly occurs in various liver diseases, it will increase the pressure in the portal vein. Why? Because the blood flow through the liver in various diseases, it is impeded, or the blood flow gets resistance to flow through the diseased liver. Normally, the pressure in the caval circulation and in the portal circulation, it is equal, and in normal conditions there is very little minor mixing of the portal blood and the caval blood. But in diseases of the liver where there is resistance to the portal blood flow to the liver before it returns to the heart through inferior vena cava, what happens that these communications, these anastomosis between the portal and caval circulation, they become important. There are 3 points where the portal and caval circulation communicate. The first is the distal portion of the esophagus. From here, most of the blood is drained through the veins directly into the superior and inferior vena cava. But the vein known as the left gastric vein, it drains its blood into the portal circulation. So what happens that normally these communication or these anastomosis make a very minute mixing of the portal and caval blood, but in diseases of the liver where the blood flow gets its resistance to flow through the liver, what happens that these anastomosing channels, they open. Automatically, when the pressure in the portal vein is increased, then pressure in the caval system, what will happen that through these communication and through these anastomosing channels, the blood will start flowing into the venous blood of the caval circulation. So one point that is situated at the distal end of the esophagus, it is responsible for esophageal varices. The second communication between the portal circulation and the caval circulation, it is at the umbilical region. Normally, in the fetus, the blood from the placenta goes through the umbilical vein into the liver through umbilical region, through umbilicus. But after birth, since placenta is no needed more, and this umbilical vein, it undergoes atrophy and is closed and is known as the ligamentum teres, or round ligament of the liver. But this is a risk channel. Whenever the pressure in the portal vein increases, this channel is reopened, and since the superficial veins are direct with the caval circulation, so there can be uh, an anastomotic channels, and whatsoever it forms is known as the caput medusa. The third communication between the caval and the portal circulation is that from blood from the rectum and the anus. It is drained by superior, inferior, and middle rectal veins into the caval circulation. But the inferior rectal vein, it drains into the portal circulation. And here when the pressure in the portal system is increased as compared to the pressure in the caval system, what happens? These veins, they swell up, they become swollen, tortuous, and uh, give rise to disease like hemorrhoids. So here we are concerned mainly with the esophageal varices. Now, what are esophageal varices? Esophageal varices, these are the most problematic and dangerous complication of the pathological portal systemic anastomosis. Physiologically, when the pressure in the caval blood and in the portal blood is equal, very little blood can be exchanged between the two circulations. But in conditions where the pressure in the portal vein is increased, the condition is known as the portal hypertension. What will happen? That the portal hypertension will cause the anastomosis between the caval and portal circulation situated at the distal end of the esophagus. The portal hypertension will cause these walls to become swollen, thick, and can potentially cause severe bleeding from this side. And these tortuous, inflamed, and swollen vessels are veins. They are known as the varices. So varices can form from the external on the external surface of the esophagus, as well as internally under the esophageal mucosa, where they protrude into the lumen of the esophagus. And these internal varices are very dangerous because bleeding from the internal varices into the lumen can be very serious, and potentially it can cause lethal complications. So here we get, when there is bleeding or hematemesis from the internal esophageal varices, we are to face two conditions. Blood loss, which if it is very severe, it can cause hypovolemic shock. We know that the major types of shock are the cardiogenic shock, hemorrhagic or hypovolemic shock, septic shock, and shock due to anaphylactic reactions and other causes. So they are hypovolemic, low volume, where we mean that if there is excessive bleeding from esophageal varices into the lumen of the esophagus, which will pass into the stomach and then into the intestine, it can cause potentially hypovolemia, and the patient can develop hypovolemic shock. Now, the second complication of this internal bleeding from the esophageal varices is that the proteins contained in the blood and red blood cells, they are broken down, and there is excess release of the ammonia. Normally, the ammonia is converted into urea in the liver, but if there is so much excess production of the ammonia, what will happen? That the liver is unable to deal with this excess ammonia, and the presence of this excess ammonia, which is a nitrogenous substance, will lead to hepatic coma due to its effects on the brain. So hepatic coma and hypovolemic shock are the serious complications of the internal esophageal varices that have ruptured, and those they bleed. Now, actually, what are varices? These are the weakened segments of the vein due to the fact that their walls are weak and thin. They become easily stretched, and their susceptibility to rupture and bleeding is more. So, in this context, the internal varices, esophageal varices, they are very more serious than the varices on the external surface of the esophagus, which have a rare chance of rupture and so heavy bleeding. Here one thing that I want to mention, that more than half of the people who die due to advanced and decompensated liver disease or cirrhosis, their death is associated with bleeding from ruptured esophageal varices. Now, simply liver cirrhosis is the major cause of portal hypertension. But if we see globally, the parasitic infection by the schistosomia that can infect the liver and known as the hepatic schistosomiasis, it is also the most common cause globally of portal hypertension. But here in our country, this type of serious parasitic infection is not so much common, and in many places the liver cirrhosis is mostly associated with chronic alcohol disease. Whatsoever, when the liver is damaged, when it becomes cirrhotic, it will resist the flow from the portal blood, and the pressure it will increase in the portal blood, and this situation is known as the portal hypertension. Now, once the flow into the portal vein becomes difficult, what will happen, that the portal and caval anastomotic channels, the portal caval anastomosis, which is situated at the distal end of the esophagus, what will happen, that these collateral veins, they will reopen, the blood will flow from the portal vein into the systemic caval circulation, and mostly these weak and thin walled anastomosing channels composed of veins, they are situated in the subepithelial and submucosal region of the wall of the esophagus. So the esophageal varices are tortuous dilated veins, particularly those veins situated in the submucosa in the wall of the esophagus, and the site of this anastomosis is the distal esophagus and proximal lateral portion of the stomach. Now, as far as these variceal veins are closed and intact, they will give little problem. But if the portal hypertension is severe, if the liver disease is severe, if the liver cirrhosis is advanced, we can get a very serious complication. These varices, they become ruptured, and there is severe bleeding, which can be in the form of hematemesis, the patient vomits blood, or some bloods that flows into the stomach and small intestine. It can give rise to uh, ammonia overload and can give rise to the hepatic encephalopathy. Now, here in this picture, the picture on the left side consists of an angiogram of esophageal varices. In angiography or in angiogram, a radiopaque dye is injected into the circulation, and this we can see through imaging techniques. Here we can see the dilated and large black colored esophageal varices. The picture on the right side, it shows that the epithelial lining of the esophageal or esophageal lumen, it is intact, but we can see blood and dilated variceal vessels under the squamous mucosa. Now, what is esophagitis? Esophagitis means esophagitis, inflammation of the esophagus. Now, this inflammation is commonly caused by physical agents, in the form of lacerations, gastroesophageal reflux disorder, radiation, swallowing hot fluids, and with smoking, which contains various chemicals that physically damage the esophagus. However, the esophagitis can also be caused by uh, an injury which is purely associated with the chemicals. For example, alcohol, corrosive oils, acids, and alkalis, chemotherapy, which is treatment for the cancers and in which we use cytotoxic drugs to kill the cancerous cells, but they also kill potentially the normal healthy cells of the body. And infections in the form of bacterial, viral, or fungal. Esophagitis may also be associated with an immune-mediated condition known as the eosinophilic esophagitis. And whenever we talk about the eosinophils, which is one of the three major granulocytes, the other two are neutrophils and basophils. So eosinophilic infiltrations, it is seen in two major conditions: the immune-mediated reactions in the form of allergy or hypersensitivity and parasitic infections. But here we get the esophagitis, which is inflammation of the esophagus characterized by infiltration of large number of eosinophils. It is associated with allergy or hypersensitivity, and the second immune mediated reaction is the graft versus host disease that we usually see in organ transplantation, when our immune system recognizes the transplant as foreign agent and develops immune reaction against these uh, transplants, and which is a major complication and which can cause failure of the transplant, also known as the transplant rejection. Now, esophageal lacerations are tears. Normally, when a person vomits, so in vomiting what happens that the food or gastric contents, they move against the peristaltic movements. Normally peristaltic movements in the esophagus, it pushes the food forward into the stomach. But if the food moves through an anti-peristaltic contraction, what happens that normally whenever the food moves against the peristalsis, there is a wave of relaxation. By what we mean that the lower esophageal sphincter opens and allow the gastric contents to enter into the esophagus to be vomited. But in situations where the lower esophageal sphincter doesn't open and doesn't relax so much to allow the contents to go into the esophagus and to be vomited, what will happen that the contents which are forced by gastric and esophageal contractions against a closed lower esophageal sphincter. And here what will happen when the lower esophageal sphincter is pushed beyond a limit? What will happen? That laceration and tears will happen in the esophagus. The most common cause of the esophageal laceration is the Mallory-Weiss syndrome. Mallory was a pathologist, the name of a pathologist, and this syndrome is the most common cause of esophageal tears. And these tears, usually they are superficial. They don't involve the whole thickness of the esophagus. And therefore, mostly the Mallory-Weiss tears, they heal in about 7 to 10 days. The most common cause is the retching. When we try to vomit, when we feel very much nauseated, but we fail to vomit. We try to omit the gastric contents. We feel severely nauseated, but we can't vomit. And in this way, there is severe pressure on the lower esophageal sphincter and the esophagus. And this pressure causes tears and lacerations. However, in Mallory-Weiss syndrome, the tears are superficial. But there is another condition which is known as the Borrego syndrome, in which the tears involve the whole thickness of the esophagus. And automatically it can cause perforation and other complications and lethal complications, because once the esophagus is ruptured, once it is perforated, so all the contents, they will be released into the peritoneal cavity and into the in the chest. They will uh, flow into the mediastinal region and can lead to lethal complications. So Mallory-Weiss syndrome, mainly it is due to pressure on the lower esophageal sphincter and uh, forceful vomiting, severe coughing, and retching will cause Mallory-Weiss tears, and our patient will present with hematemesis, that is blood in the vomiting, melena, blood in the stool. Usually uh, it results in black tarry stools, because the red blood cells contained in the blood, they are acted upon by the bacteria and they are broken down and they give a black color to the stool. But in hematemesis we may have fresh blood. The Mallory-Weiss syndrome also can cause dizziness and sometimes severe abdominal pain. To make the diagnosis, we look for the sign and symptoms, but the definitive diagnosis is made by inserting an endoscope and to see the tears. Now, the treatment of these esophageal tears is what we can do is to avoid the triggers and to treat medically by giving certain medicines as appropriate for the patient. But if these procedures fail and if vomiting is continued, making the tears and uh, ruptures more and more severe, then we will need endoscopic or surgical intervention to close the tears and ruptures. In this picture, uh, in Mallory-Weiss syndrome, this is endoscopic picture, and the arrow will indicate the presence of blood and tears or lacerations in the esophageal mucosa. And in the second picture, uh, we can see the tears and lacerations caused in Mallory-Weiss syndrome. Now, in esophagitis, as we mentioned that esophagitis may be caused by Mallory-Weiss syndrome or the more severe Borrego syndrome, which involves the whole thickness of the esophagus and which can have serious and lethal complications. The esophagus can become inflamed by certain chemicals. Now, the esophageal mucosa, it can be damaged by a variety of irritants. For example, alcohol, corrosive acids, and alkalis. And if a person takes very hot fluid, and particularly in heavy smokers, where the contents of the smoke, it damages physically the esophagus along with the trachea and lung. Sometimes we take a medicinal pill. So mostly there are medicines that are very irritating to the esophagus, and uh, uh, we want these medicines to be released in the stomach and carried to the stomach in a safe form. These medicines are contained in coated tablets and capsules. But sometimes the capsule, before it reaches into the stomach and acted upon by the stomach contents to release the medicines, the pill is ruptured in the esophagus. And this situation is known as the pill-induced esophagitis. Because the medicine contained in the film-coated tablet or capsule, they are released in the esophagus and they cause irritation. Sometimes iatrogenic esophageal injury. Iatrogenic means that by treating one condition, we produce another problem in the patient. So this is an induced type of esophageal injury, and the conditions that can give rise to iatrogenic esophageal injury include cytotoxic drugs, chemotherapy, particularly when we use drugs to kill cancer cells, when we use radiation to for the treatment of a cancer, but along with the cancer we damage the nearby healthy area, and it can include the esophagus. And the immune mediated conditions, as we discussed, the graft versus host disease. Usually the esophagitis due to chemical injury cause mild signs and symptoms in the form of difficulty in swallowing known as the dysphagia, and pain which is felt during the swallowing known as the adenophagia, painful swallowing. Sometimes, rarely, these irritants and their induced esophagitis can be very serious, and potentially it can lead to bleeding, structure formation, and if the injury is very severe, it can cause perforation with its lethal complications. Morphologically, the changes that we see grossly and under the microscope, they are non-specific. We see ulceration and infiltration of neutrophils, which are acute inflammatory cells, and particularly their infiltration is associated with acute infections. And sometimes the radiation that we use for certain diseases, it may cause the blood vessels thickening in the area which is radiated, where we are using radiation. And when the blood vessels they are injured, this radiation is now adding an element of ischemic injury. Infections, infectious esophagitis is more severe and very complicated if it occurs in patients who are debilitated by other diseases, or patients who are immunosuppressed or immunocompromised, as compared to the healthy persons, where cause they will they will not cause very serious problem. Particularly in immunocompressed or immunocompromised patients, the fungal infections and bacterial infections, they are a problem of great concern sometimes. So the infection may be primarily of the esophagus, or it may be associated, and it may be as a complication of a pre-existing injury or ulcer in the esophagus. So if there is an ulcer that is already present in the esophagus, so the infection will be more common in that region. The common microorganisms that infect the esophagus include the viruses, herpes simplex virus, cytomegalovirus virus, and the fungus which commonly affects the esophagus is the candida. The pathogenic organisms may invade the lamina propria and cause necrosis of the overlying mucosa. We know that on cross section of the esophagus we see the mucosa lying on the basement membrane known as the lamina propria, then the muscularis mucosa, then the submucosa, then the muscularis externa, and the serosa. So the pathogenic organisms, they can cause infection which may cross over the basement membrane or the lamina propria, and that will lead to the necrosis of the underlying stratified squamous epithelial lining or mucosa. Now, since the causes are different in the form of viruses, bacteria, fungals, uh, uh, other microorganisms, and autoimmune reactions. So, how we will diagnose these cases? Different histopathological, microbiological, and certain serological tests, which are specific for each of the causes, that may be fungal, bacterial, parasitic, viral. So, we will use various pathological techniques for the identification and diagnosis of these microorganisms. In this picture, uh, the picture on the left side, picture A, it is taken from a person who was dead. Therefore, we say post-mortem specimen. And here we can see multiple herpetic ulcers in the distal esophagus. And here in this picture B, we see the squamous cells uh, which appear as multinucleated, and they contain the herpes virus nuclear enclations. And in the picture C, this is the CMV cytomegalovirus infected endothelial cells lining the blood vessels, and we can see the nuclear and cytoplasmic enclations in this picture. Thank you very much.